CVS Part 1 Case Study 12.
A 59-year-old man presents with progressive exertional dyspnea, fatigue, abdominal distension and bilateral lower extremity swelling over 2 years. Initially, he could walk several blocks, but now becomes short of breath after walking 50 meters. He also reports early satiety and orthopnea, requiring 2 pillows. He denies chest pain, fever, hemoptysis or syncope. His medical history includes long-standing hypertension, bilateral carpal tunnel syndrome, lumbar spinal stenosis and prior biceps tendon rupture. 3 years earlier, he was diagnosed with heart failure with preserved ejection fraction after an echocardiogram shows thickened ventricular walls, bilateral enlargement and normal systolic function. At that time, his symptoms improved with low-dose diuretics and blood pressure control. Over the past year, he has experienced progressive worsening despite adherence to the therapy. A repeat echo shows dilated left ventricle, severe global hypokinesis, left ventricular ejection fraction 28%, marked by atrial enlargement, restrictive filling patterns. Cardiac MRI previously demonstrated diffuse late gadolinium enhancement and endomyocardial biopsy confirms amyloid deposition. On examination, blood pressure 98/64, heart rate 104, elevated JVP, S3 gallop, bibasilar crackles, ascites and bilateral pitting edema, cool extremities with orthostatic symptoms. Laboratory findings: BNP markedly elevated, creatinine 1.9, sodium 128, mildly elevated troponin. Right heart catheterization shows elevated filling pressures, low cardiac index and elevated SVR. Which of the following best explains the change in treatment strategy from early stage of the disease to the current stage? Option A. In heart failure with preserved ejection fraction, diuretics are avoided, whereas in reduced ejection fraction, vasodilators are contraindicated. Option B. Early restrictive cardiomyopathy presents with impaired ventricular filling and preserved systolic function, whereas disease progression leads to systolic dysfunction and neurohormonal activation, necessitating transition to the guideline-directed therapy for reduced EF. Option C. Restrictive cardiomyopathy always remains associated with preserved EF and the current findings represent measurement variability. Option D. The decline in ejection fraction indicates isolated right ventricular failure requiring pulmonary vasodilator therapy. Option E. The reduction in ejection fraction signifies resolution of heart failure and need only for renal protective therapy.
So, this is a case of non-ischemic cardiomyopathy, which is restrictive cardiomyopathy in this case. Now, how it progresses? Primarily, the restrictive cardiomyopathy presents as heart failure with preserved ejection fraction. In this phase, it is diastolic dysfunction, where there is impaired relaxation of the left ventricle, leading to pooling of blood into the left ventricle, congesting back to the left atrium, and leading to a high PCWP and congestion in the pulmonary circuit backwards. So, this is what is happening in HFpEF. Now, as the disease progresses to reduced compliance, means there is the restrictive cardiomyopathy progresses and there is reduced compliance and poor contractility of the left ventricle, the disease progresses to systolic dysfunction with reduced ejection fraction and leads to cardiogenic shock. That is impaired oxygen delivery and an increased myocardial oxygen demand and the oxygen demand from the other vital organs. So, the neurohormonal compensatory mechanisms get activated. And what are these neurohormonal compensatory mechanisms? Number 1, the activation of the systemic nervous system, that is release of the catecholamines, which will increase the systemic vascular resistance and the cardiac output by increasing the force of contraction. Number 2 is the activation of the renin-angiotensin-aldosterone system, which will again lead to vasoconstriction and the vasopressor effect, that is diverting the blood to the vital organs. And number 3 is the release of the antidiuretic hormone, the vasopressin, which will lead to preservation of water and increasing the circulating blood volume into the body. So, this activation of the neurohormonal compensatory mechanisms leads to a very high SVR, which again becomes a reason for pump failure. So it has started as compensation, but it is a downward spiral. For the weak heart, which is not able to pump the blood, it becomes a problem. The increased SVR becomes a problem for the weak heart, for the weak pump, as the weak pump has to push the blood against an increased afterload. So in cases, we need to optimize the SVR so that the heart is not failing further and it is not dying out faster. So what we have seen, that initial phase of diastolic dysfunction, a careful diuresis will decongest the heart, and along with, when the increased SVR becomes a problem for the dying heart, then we need to optimize the SVR as well. So this is the theory on which we have to progress for the restrictive cardiomyopathy, which is progressing in its course. Now excluding the wrong options and selecting the right option.
Option A. In heart failure with preserved ejection fraction, diuretics are avoided, whereas in reduced ejection fraction, vasodilators are contraindicated.
So this is just the opposite statement. In diastolic dysfunction, that is heart failure with preserved ejection fraction, diuretics are not avoided, diuretics are indicated. And in reduced ejection fraction, when the heart has become weak, the pump has become weak, there is pump failure, we need to optimize the SVR with vasodilators.
Option B. Early restrictive cardiomyopathy presents with impaired ventricular filling and preserved systolic function, whereas disease progression leads to systolic dysfunction and neurohormonal activation, necessitating transition to the guideline-directed therapy for reduced ejection fraction, which is correct.
This is the correct option.
Option C. Restrictive cardiomyopathy always remains associated with preserved ejection fraction, and the current findings represent measurement variability.
Restrictive cardiomyopathy always does not stick to preserved ejection fraction. Progression of the disease leads to reduced ejection fraction.
Option D. The decline in ejection fraction indicates isolated right ventricular failure requiring pulmonary vasodilator therapy.
It is not isolated right ventricular failure.
Option E. The reduction in ejection fraction signifies resolution of heart failure and need only for renal protective therapy.
There is progression of heart failure and not resolution.
That's right.
Search Edumedex on Instagram and YouTube to start your journey today.